So as you grow older, there are obvious concerns about multiple pharmacotherapy agents being used for pain control and interactions. There's cognitive deficits that we need to be aware of that can get worse with these certain agents that we give patients for pain control. At the same time, there's end organ dysfunction. Kidneys might not be working as well, and clearance of these medications can be a concern. Other types of issues, such as heart dysfunction, might not be very good candidates for even some of the adjuvant medications that we try to encourage. Things like tricyclic antidepressants for pain, which can be helpful, might not be a prudent decision in an elderly patient. So both the interactions of the medications that they're already on, as well as their current status, with their comorbidities, might hinder practitioners in being able to help control their pain. And then unfortunately, they might feel like they need to increase their opioid use, but again, that just makes it a higher fall risk. Nobody wants their patient to end up having a broken hip after a fall. It's a big risk. So, and obviously the cognitive deficits, these are all things to be concerned about in the elderly. Well, there's some common pain complaints that you'll see in the elderly. Things like sacroiliitis, chronic low back pain that might be due to facetogenic osteoarthritis. These are conditions that we can see anywhere from 25 to 40% of patients, and even more so in the elderly who complain of chronic low back pain. And there are different types of treatment options, and one of the most promising things is radiofrequency ablation that can give long-term relief, 6 months to a year. It can be repeated, as these nerves grow back, and with very low risk associated with them, and can provide a much better way of taking care of their pain without necessarily having to resort to multi-pharmacotherapy. And with the growing trend of knee pain in the United States, there's now newer techniques like what we call genicular radiofrequency, which we can target these small little nerves in the knee that can provide extreme relief in patients who either are too old to have surgery or have too many comorbidities and they're not surgical candidates, or for patients who have already had knee replacements. As much as 15 to 20% of patients who already have had a knee replacement can still have persistent pain after their knee replacement. And what do you do then? You're not going to inject steroid. There's no real joint there. So, in the past we were relegated to having to prescribe opioids or whatnot, but now this is a good option for those patients. You have to be careful, with the types of medications that you prescribe, the dosages that you prescribe, and then just to be cognizant that there are other strategies and other interventional approaches that you could use to your benefit, so that you can use as leverage against having to relegate yourself to prescribing possibly high-risk medications in this age group.